respected dignitaries right in the front row and in the audience. Actually, the correct Marathi word for this is dabdaba. So, such is the dabdaba of Satyavan Sharma sir and Pehla Jani sir. We are actually starting before time, 2 minutes before time. So, I think we'll wait for a couple of minutes. But in the meanwhile, so we are having a number of sessions over the next 2 days, and we have tried to cover the best of what has happened in the last year or year and a half, the advances, so to say. And all kinds of topics will be covered, like heart failure, then the guidelines, ischemic heart disease, coronary imaging, structural and congenital heart, structural interventions, electrophysiology. So we are starting off with the guidelines. There were a number of interesting guidelines that came up in the last year or so. So I invite the chairpersons for the first session, Dr. Akshay Mehta sir and Dr. Anil Sharma sir, to please take their places and to please start the session in due time. Thank you.
Thank you, Dr. Milind. Good afternoon and welcome you all. And without wasting a time, we are starting with the first session, highlights from 2023 guidelines. ESC guidelines about hypertension, the commonest disease, and another common disease is ACS and CCS, and how they are applicable to the Indian patients. First speaker is to speak on ESC guidelines for hypertension, Dr. Hetan Shah. Dr. Hetan, welcome.
Hello everyone. Thank you Pehla Jani sir and Satyavan Sharma sir, and respect all organizers. And Ajit Desai sir. This is, I think this AOC meeting has a very peculiar aspect that every year with the new theme, it is not the monotony like other. And this topic has been selected, it's all, I think, vision of the dignitaries like Pehla Jani sir and Satyavan Sharma and Ajit Desai sir. This is like a excellent topic in day-to-day practice, and such discussions make us wiser how to implement our this guidelines in our practice. So my topic is today is about the ESC guidelines of hypertension, which has been published in 2023. As we know that hypertension is a major modifiable risk factor for coronary artery disease, heart failure, stroke, and kidney disease. And last year, 2023, we celebrated 28th anniversary of hypertension, and Professor Alberto had published these guidelines in ESC. And what is the new about this? Just brief about this. It gives you the gist about the BP measurement, the new terminology, hypertension-mediated organ dysfunctions, the new severe risk factors, updates on the lifestyle interventions, and different how to manage the resistant hypertension. It is again one of the major issues, and the different phenotypes, and how to make the patient adherent and the follow-up strategies. So hypertension, as we know, that it is of two disorders, the primary and the secondary. Primary we known as I can say it is essential, and it is usually due to a RAS or a central or a peripheral autonomic nervous system. But the most common is the genetic. Almost 100 genetic factors are responsible for the hypertensions. But superimposed by the environmental, that is air pollutions today's era, the temperature variability, the noise pollutions, and the lifestyle factors. And the other, I can say, the secondary hypertension, it carries almost a small fractions of percentage of the patients. So in this year, they found that they had not only stage, but according to the grade of the hypertension, then normally the definitions, according to ACHA, it was 130 by 80, but here they had imposed 140 by 90, you have to start the treatment. And then those who are having a single day of more than 2 episodes, and stage 1 is uncomplicated hypertension. Here there is no risk factor. It is a straightway BP of more than 140 by 90, but it is uncomplicated. Stage 2 is patients with associated diabetes mellitus, CKD, or hypertension mediated. We will discuss in detail. And or they are with grade 3 hypertension. They are called as a stage 2. And the stage 3 is a established CVD with a CKD of more than grade 4. So the difference between the ACC AHA guidelines and this is almost the BP goals are the same. But here the major this thing is the normal they had given at the range of 130 by 80. Here up to 140 by 80 you should wait, and then you can start the treatment if there is associations of HMOD or severe risk factors. But the major breakthrough is here the beta blocker they had considered as a first line therapy in hypertension compared to previous guidelines. And the risk assessment by the score 2 and the score in elderly patients, it is based on the age, sex, smoking pattern, the lipids level, and they risk stratified the individuals, whether they falls into the high risk, intermediate risk, or a very high risk category. And the BP measurement, I think everybody knows the standard technique is not only the measurement technique, but the posture, the condition, everything is responsible. And there are, I think in today's era, we are all bombarded with a lot of devices. So the auscultatory method, the mercury, the Android, they are the gold standard. Then the other like oscillometry and what we are seeing is like all wearable devices. They are non-cuff, without cuff, cuffless devices. But still they are not validated according to the guidelines. You can diagnose, they are not true for the diagnosis. They are helpful for the creating the awareness and the treatment modalities. And the 24-hour ABPM, HBM, the home BP monitoring is also a good for supportive and the treatment aspect. But the gold standard is office BP monitoring, one shot, or clinic BP monitoring. And if more than 2 readings are high, then you should suspect the patient. And the central venous pressure, I think in a cath we can see with the arterial lines. So central and the peripheral, it is because it is invasive, you can directly measure and with the brachial interventions or sphygmomanometer with the mercury or automated. What are the difference? There is a 5 to 10 millimeter difference in the blood pressures. So the recommendation is ideally the office BP or clinic BP, but you may get a mimic by the white coat hypertensions or mask hypertensions. Then in that case is home BP. But the guideline says that at least 7 days home BP monitoring, morning and evening, and less than 3 days are not valid. Same thing is with the 24-hour ambulatory BP monitoring. In 24 hours, at least 20 reading has to be there. So a gap of 20 minutes during daytime and during sleep pattern, the gap of more than 1 hour, one should monitor the BP and take a average of it. So the guideline says that again auscultatory, that mercury or mercury less Android BP measurements are the gold standard, but the cuffless devices are not used for the evaluations and the management. They are helpful for the creating the awareness. All smart watches are having a cuffless, but they are useful for creating awareness. One can be conscious, but they are not useful for the treatment strategy. And another important aspect is home BP. That is very essential because ABPM has its own role, but it is costly and you can monitor really. But if you educate the person or patient and you train them, and the home BP will help you in monitoring and the follow-up management will be very easy. So, and that will help you to differentiate the mask and white coat hypertensions too. But the home BP, the goal should be 135 by 85. It is the office BP 140 by 90. And the ABPM, as I said, it is mandatory, but it is usually used for true resistance hypertension. And I would say like a diabetic individual, because ABPM, what we are saying is not only the daytime, but the nocturnal pattern. And the dipping, non-dipping predicts the future cardiovascular risk. So here, in a patient with diabetic, you want to assess the futures. In that individuals, if you perform a ABPM, that gives you the idea about the nocturnal hypertensions, and you can unmask the hypertensions and treat aggressively for the severe risk factors. And the word about the HMOD, the hypertension mediated organ dysfunction. that is it is intermediate risk assessment between the CV risk and the development of the cardiovascular disease in the form of heart, LVH, the arterial stiffness, the carotid intermediate thickness, or ankle brachial index, and that carries an important prognosis value. The secondary hypertensions, like any patients with unexplained high blood pressure of grade 2, usually according to age, the younger age group is like a coarctations, middle aortic arch syndrome, but the older age is like a renal and renovascular, that may be either fibromuscular dysplasia or atherosclerotic coronary artery disease. And the other form of secondary hypertension, here I think drug history is very important, because the steroid, now all the patients, I think you can see the malignancy is a tsunami of cases we are seeing. The cancer treatment, the therapy also leads to hypertension. So the drug history also leads to secondary hypertension, and other forms are like primary hyperaldosteronism, Cushing syndromes and all. So when to initiate the treatment, your goal is to 140/90, and then initially you advise the lifestyle modifications in the form of salt restrictions. It should be less than 5 gram. Second thing is in the form of weight reductions and the control of other risk factor, smoking and all. And then you start the treatment. And your goal, once the patient has achieved 140/90, then your goal is to reduce further by 130/80. But less than 120/80, and this guideline says even diastolic BP less than 90 is not advisable. So better you should prefer that range in a better way. So the age group, if the person is above 80, then your goal should be around 160. Or if patient is not frail and above 80, well preserved, then your goal is around 150. So, and this guideline says, not the diuretic as a first line, but the ACE inhibitor or ARB with calcium channel blocker, single pill monotherapy, but combinations. A morning dose is advisable, and then you can add on the things, the beta blockers, the diuretic, according to the need. And most of the time, the 60% of the time, the blood pressure is well controlled with the CCBs. And if 90%, you may take a help of triple drug combinations. And then we may, 5% of the cases, we may a scenario like a resistant hypertension. Here, you have to add centrally acting drug, and now today's we are leading forwards for the renal denervations, and this ESC guideline had mentions the role of renal denervation in a selected cases after this simplicity trial, that it's a robustic effect. So if eGFR of more than 40, then one should recommend RDN in such patients. And patients with coronary artery disease, just 2 minutes. Coronary artery disease, the role of beta blocker is mandatory. And patients with stroke, if it is hemorrhagic or non-ischemic. Hemorrhagic, your goal is 140, and ischemic, your goal is above less than 180. But if it is more than 6 hours, your reduction should not be fast. It should be in a moderations. And diabetic, as I said, the ABPM lifestyle modifications, and here there is a role of SGLT2 and inhibitor. So same thing is reduce EF and the preserve EF, all 4 standard guideline directed therapy, ARNI, there is a role, and HEPF, SGLT2 takeover. And as I said, the cancer also plays a very important role, and one should not miss that history and of the drug and the treatment itself. And lastly, not the list, the adherence. Adherence has to be proper, because almost all meta-analysis say that 50% of the patient being diagnosed case of hypertension, but they are over-the-counter treatment and they are not being followed properly. So every 3 monthly and 1 yearly follow-up has to be there, and you have to prescribe the drug in a same way that monotherapy, combination therapy, and patient compliance we can improve. Thank you. Yeah.
Thank you very much, madam, for wonderful talk. We'll have panel discussion after all 3 talks are there.